Hello guys, welcome to podcast 21 of Let's Revise MBBS, and today's topic is going to be very interesting. So we are going to talk about labor. Okay, so first we'll see about normal versus abnormal labor, then we'll see cause of labor, why does labor happen, then we will see some stages of labor. Okay, 4 stages of labor, right? So what is normal labor? So there are certain conditions to be met before we call it a normal labor. So it should start at 37 weeks or beyond, and it should be spontaneous in onset. Okay, that's the first point. Second is the baby should have vertex presentation. The process of labor shouldn't be prolonged. Okay, it should need minimum help like episiotomy, just minimum interventions. Okay, and there should not be any complications. The outcome should be good for the mother as well as fetus. If these conditions are met, then we call it as a normal labor. Any deviation from this becomes abnormal labor. So there are 3 P's involved in labor, that is power, passenger and passage. Okay, any abnormality in this can cause abnormal labor. So abnormality in power causes uterine inertia. Okay, that means the uterus is not contracting. So this factor is correctable. We can give her oxytocin or other drugs and we can correct this. But other two, that is passage and passenger. So in passage there can be contracted pelvis. We talked about contracted pelvis yesterday, and there can be CPD. Okay, and in passenger there can be transverse lie or brow presentation. Okay, and CPD can also come in passenger. So for passage and passenger, most of the time we need to go for C-section, and uterine inertia is most of the time correctable. Okay, now let's see how the labor begins. Okay, what is the stimulus and how it begins. So for this, the fetal hypothalamus pituitary adrenal axis should be functional. This is very important. Okay, so when the hypothalamus is developed, it secretes CRH, corticotropin releasing hormone. Okay, and this CRF, yeah. So this CRF stimulates pituitary to secrete ACTH, and this ACTH again stimulates adrenal to release cortisol. Okay, till this we know. Now this cortisol normally should give a negative feedback to CRH. Okay, but it goes in the placenta and stimulates placental CRH positively. This is the main point here. So cortisol is giving a positive feedback to placental CRH. Okay, and then this placental CRH is again stimulating the fetal ACTH, and it helps to increase cortisol again. So this is like a positive feedback mechanism. So what is the role of placental CRH? It has 3 main functions. It increases estrogen production, prostaglandin production and interleukin production. So we have seen how is the progesterone produced in pregnancy. We have seen about most of the hormones, but we haven't seen about estrogen. So how is estrogen produced? It is mainly produced from fetal DHEAS, dihydroepiandrostenedione sulfate. So this DHEAS is secreted by fetal adrenal glands. It goes into the placenta, and there it is converted to estrogen. So since placental CRH is stimulating the production of cortisol in the fetus, and also DHEAS, this DHEAS will get converted into estrogen, and eventually production of estrogen will rise. So that's how it stimulates estrogen production. Okay, and it also stimulates prostaglandin and interleukin production. So these 3 stimulate the uterus to contract more vigorously, and then the placenta also stimulates decidua of uterus, and then the decidua produces PGF2 alpha. Okay, so let me summarize the final functions of placental CRH. It increases oxytocin receptors, estrogen production and estrogen receptors. It increases prostaglandin. It decreases progesterone receptors, and it increases stretch receptors. Okay, so due to all this, the process of labor begins. So the main hormone the initial main hormone is fetal CRH. Okay, and the cortisol is giving positive feedback to placental CRH. Right, now let's talk about stages of labor. So basically there are 4 stages. First stage is from onset of true labor to full dilatation of cervix, that is till 10 centimeter. The second stage is from full dilatation of cervix to the delivery of fetus. Third stage is delivery of placenta, and fourth stage is just the observation period. So in the first stage we said that it begins from true labor. So what is true labor? How will you differentiate between true labor and false labor? So true labor radiates to back, radiates to thighs. Then true labor, the pain is not relieved by sedation in true labor. Okay, the frequency and intensity of contractions goes on increasing in true labor, and true labor is accompanied by dilatation of cervix. So these all are the characteristics of true labor. So if these are not present, then you consider it as false labor. Okay, now in the first stage we have divided into 2 further stages. The first is latent stage and then the active stage. Okay, the latent stage is from 0 centimeters to 5 centimeters dilatation of cervix, and in active it is from 6 to 10 centimeters. Okay, now in all the stages we will talk about their average time period of that particular stage and maximum time period, and it will be different for nulliparous woman and multiparous woman. Why? Because nulliparous woman is first time delivering a child, so the pelvic wall will be slightly rigid, so it will take more time for nulliparous as compared to multiparous. Okay, so now talking about the latent phase, the average duration for latent phase is 12 hours for nulliparous and 8 hours for multiparous. This is the average time which they require, but maximum which latent phase can extend up to is 20 hours for nulliparous and 14 hours for multiparous. Okay, right. So when do we call this as prolonged? When do we call that latent phase has been prolonged? So the maximum time was 20 hours for nulliparous and 14 hours for multiparous. So above this, if the time required is more than this 20 and 14 hours, then we call it as prolonged latent phase. And how do we manage it? We mostly give the rest to the patient, and if required we can apply Cerviprime gel. Okay, now let's talk about active phase. So active phase is from 6 centimeters to 10 centimeters. Here we do not give a specific timing for active phase. We talk about the rate of dilatation of cervix. Okay, so in nulliparous the rate should be 1.2 centimeters per hour, and in multiparous it should be 1.5 centimeter per hour. Okay, this is normal. This should be there, but minimum 1 centimeter per hour should be there. The minimum rate is 1 centimeter per hour. Average is 1.2 for nulliparous and 1.5 for multiparous. Okay, now in active phase there is descent of the baby also going on simultaneously. So what should be the rate of descent? It should be 1 centimeter per hour in nulliparous and 2 centimeter per hour in multiparous. Okay, now what can be the problems with this active phase? There can either be protracted active phase and arrested active phase. So protracted is the active phase is going on, but the rate has become slower. Okay, it's going at a slower rate. So what can be the causes for this? It can be either CPD, cephalopelvic disproportion. So you need to rule out whether it's CPD or not. If it is CPD, then as we discussed yesterday, we need to take the patient for C-section. Okay, then if it's not CPD, then we check whether it is occipito-posterior position. Okay, since occipito-posterior position may take a longer time for delivery. So if it is occipito-posterior position, then we wait and watch. Okay, since occipito-posterior is going to require more time. If it is neither CPD nor occipito-posterior, then we augment the labor. What is augmentation? We try to increase the rate of labor. How can we do that? First we do ARM, artificial rupture of membrane, and then this after the rupture of membranes, prostaglandins are released, and then the contractions can increase. If they don't increase, then we wait for 30 minutes. Even after 30 minutes, if they don't increase, then we give oxytocin. Okay, remember we don't have to do augmentation and simultaneously give oxytocin. It can cause a lot of contraction and uterus can go in tachysystole. Okay, that's why we wait for 30 minutes. Now this was about prolonged active phase. Now what about arrest of active phase? What is arrest? When the membranes are ruptured and uterus is adequately contracting, even after that we wait for 4 hours, and in 4 hours there is no cervical dilatation, then we call it arrested active phase of first stage of labor. Okay, so here in arrest of first stage the only management is C-section. Okay, so that was about first stage. Now let's come on to the second stage. What is the second stage? Full dilatation of cervix to delivery of placenta. Delivery of fetus. Okay, full stage of dilatation to delivery of fetus. So again here in nulliparous and multiparous the average duration is 1 hour and 30 minutes respectively. Okay, average duration. Maximum is 2 hours and 1 hour. 2 hours in nulliparous and 1 hour in multiparous. Okay, so if the time is more than 2 hours or more than 1 hour, then we call it as prolonged second stage. Okay, and if it is more than 3 hours and more than 2 hours in nulliparous and multiparous respectively, then we call it arrest of second stage. Okay, so 1 hour 30 minutes normal, 2 hours, more than 2 hours 1 hour prolonged, and more than 3 hours and 2 hours is arrest. Okay, in case the patient is given epidural anesthesia, then you increase the time by 1 hour each. Okay, so the prolonged becomes 3 hours and 2 hours, and arrested second stage becomes 4 hours and 3 hours if epidural anesthesia is given. Okay, so how do you manage prolonged stage of labor? So in prolonged stage we see the station of the baby. So we have seen that at the level of ischial spine the station is 0. Above that there is minus till -5. Every centimeter we increase to -5, and below the ischial spines it's still +5. Okay, so if the station of the baby is +2 or below that and the second stage is getting prolonged, we go for instrumental delivery. And if the second stage, if the station of the baby is less than +2, above +2, then we go for C-section. Okay, now if the second stage is arrested second stage means the labor is obstructed. It's obstructed labor. So what will be the features of obstructed labor? In the mother will be exhausted. Okay, tachypneic, she will be tachypneic, and we may see Bandel's ring. Bandel's ring is retraction ring, which is due to excessive contraction of upper segment of uterus and stretching of lower segment. So at the per abdominally we can visualize this Bandel ring, and it is present near the umbilicus. Okay, so these are changes in mother. In fetus, fetus may go in distress, so molding may be seen. What is molding? It is overlapping of the bones, parietal bones mainly. Okay, we'll talk about the grading of molding later. And there can be caput succedaneum. So caput succedaneum is basically collection of fluid under the scalp. This is because there is obstruction of venous return and there is edema, continuous edema going on. Okay, so these all features can be seen in fetus. How do we manage this? Arrested second stage or obstructed labor? C-section, right? Okay, now coming on to the third stage. Third stage is delivery of placenta. So nowadays we are actively intervening and delivering the placenta to decrease the amount of blood loss. So average duration for third stage in nulliparous is 15 minutes and in multiparous is 5 minutes. Okay, maximum it can be 30 minutes. If it is more than 30 minutes, that means the third stage is prolonged. Okay, and the most common cause of prolongation of third stage of labor is atony of uterus. The tone of uterus is lost. So there can be retained bits of placenta. So how do we manage this? We give her oxytocin, because the most common cause is atony of uterus. We give her oxytocin, and most of the cases are resolved. In most of the cases the placenta is delivered. But if still the placenta is not delivered, then there can be two causes. Either the placenta is morbidly adherent or it is not adherent. So if it is not adherent, then, and even after giving oxytocin, placenta is not delivered, then we need to give the patient general anesthesia, put our hand inside the uterus and remove the placenta. Okay? But if the placenta is adherent, morbidly adherent, that is placenta increta, percreta, accreta, if that's the case, then we need to go for hysterectomy. Okay? So what are the signs of placental separation? So there will be sudden gush of blood, there will be lengthening of umbilical cord. Okay? We can feel the placenta in vagina, and there can be suprapubic bulge. So these are some signs by which we can understand that placenta has separated. Okay? What are the methods of separation methods of placenta? Two methods: central, peripheral. Central method is known as Schultz method, and peripheral method is called Duncan method. Okay? In Schultz method there is less amount of bleeding. In Duncan's method there is more bleeding. Okay? So this was third stage, and the last stage, which is stage 4, is just the observation period. We observe the patient for any complication. The common complication occurring in stage 4 is PPH, postpartum hemorrhage. Okay? So we'll continue the labor in the next podcast. Okay? Bye bye.